Awesome. Right. Hi, everybody, and welcome to our monthly meeting for International Women in Biomechanics. Anna is unfortunately in another meeting at the moment, so we've got me for the announcements and the general welcome, and then I'll hand over to our monthly meeting committee and our speakers, and we can get started. So the main kind of purpose of this meeting is we've got several members who are here to share their research with us, and hopefully people will be able to kind of ask questions and be interested in the content that's being presented, so we'll be able to have a bit of a discussion. So thanks so much to everybody who has agreed to speak today. Before we get started, just got a few announcements. So next slide, please. Chris Whitty reference for those in the UK. So we've got our, if you just jump back one, I think we've got one before there. She says hopefully.
Sorry, I'm having all these admit
Fair.
pop-ups.
Other way.
It's just not working at all. Hold on.
Oh. There we are.
Sorry.
There we go. Okay. Brilliant. So hopefully you'll all have received our new monthly newsletter. So one thing that we've added to this, based on kind of feedback from everybody, is a roundup of what's been happening in Slack over the last month. So hopefully kind of everybody's keeping an eye on Slack and participating in the discussion, but we're also kind of flagging conversations that are going on in case there's anything that's popped up that people think that they can add to or participate in. If you have anything that you want to add to our newsletter, then please let us know. So you can just send it to our usual email address and we'll include that in the next monthly newsletter. The other thing that we include in there, that we've included in there, is, oh, someone's mic open. If you need to update your email address for IWB to receive these newsletters and so on, and the information for how to do so is in it. So you can always go through that process. We're also going to put that on our website or post on Slack if you get stuck, just to make sure we've got contact email addresses for everyone. Next slide, please. Recording from our September meeting is now available. So for anyone that wasn't there in the meeting and hasn't had a chance to check this out, this was really exciting. We went through an overview of IWB's various activities at the summer conferences. Somehow looking back at it, we seem to have done an awful lot in a load of different places in collaboration with other groups, workshops that we ran at NACOB, Women in Science events that we were part of, and events at World Congress of Biomechanics as well. So you can find that on our YouTube channel, the recordings there. So make sure you check that out if you haven't had a chance to look at it already. Next one. Oh, yeah. And as we were talking about the workshop and so on, all the resources that we've put together for all of these events are stored in our repository, which you can find at the link there where it says see previous events. If you have resources to add to this, then again, please let us know, contact us via email. We're gathering resources, expanding beyond just Women in Science events to have more things that we can kind of share with everyone as a community. And Nikita or Tamaya might be reaching out to you if you've previously indicated that you've got resources that you would be willing to share with us. So keep an eye out for their Slack messages or emails if that applies to you. Next one, please. Okay, paper of the quarter. So part of what we do is to try to increase the visibility of science that's done by our members, our Women in Biomechanics, and the social media team. You've hopefully seen these on Twitter, have put together quarterly papers that highlight our science. We've got a vacancy for our next quarterly paper, our paper of the quarter. So if you have a recent paper that you would like us to share, send Freya Watson a message via Twitter or message her on Slack, and we'll help you to put that together. We'll put that together with your work, with your assistance. You can have a look back and see the last ones that have been done. They're a really nice way of kind of getting your work out there and sharing your message. So please do kind of get in touch with us. And so next one then. Awesome. So blog, I'll hand over to Alexa.
Hi, I just want to kind of let everybody know an update on kind of what we've been doing on our blog. If you haven't seen it, we are recapping the Diversifying Your Workplace pre-conference workshop that we put on at NACOB alongside BBA and LIB. And so there were 5 different topics, and we're kind of recapping each of those topics. So you see, we've kind of done an intro, put out 1 through 3, 4 will come later today, 5 will be next week, and then we'll kind of wrap it all up. But check these out because they all are pretty awesome. They provide a lot of great resources if you weren't able to make it to NACOB and make it to this pre-conference workshop. And just kind of a special thank you to BBA and LIB for helping us put this together in terms of the workshop itself and putting these blogs together. And kind of in line with some things that you'll hear about for the next few meetings. If you're interested in writing a blog about your experience in undergrad research or your grad programs, please reach out to me. We would be happy to have them. We kind of have some, you can write generally about kind of your experiences, or if there's something specifically that you want to talk about, we're love to hear about it. So please let me know if that's something that you would be interested in doing.
Hi, we also have a grant. It's the National Biomechanics Day grant. This is for master or PhD students in biomechanics who plan to create a National Biomechanics Day event. The aim of this grant is to promote women in biomechanics. And the event that you can host can be virtual as well. And if you feel like organizing an event and you would like to get some support, then please apply for this National Biomechanics Day grant by 14th of February. Thank you.
Okay, so have we got Ramanda here, or is she not made it?
She just entered the room, so let's give her a second and she will talk about this slide.
Okay, all right. Perfect timing.
Ramanda, you signed in just in time. Can you talk to us about Black History Month?
Oh, hi. So it is currently Black History Month in the United Kingdom, and this month BASIS has teamed up with the Black Biomechanics Association to promote and uplift Black biomechanics worldwide. So if you know anybody who's a Black biomechanics and are working, please share this link with them or tell them to get in contact with me. We would love to highlight them throughout the month. Highlights will be going every Tuesday and Thursday of this month. So we would love to highlight them or their research. If y'all know any Black biomechanics who have put out research, and submit those articles to me. We just want to highlight in every way possible Black biomechanics who's working throughout the world.
Okay, great. So that brings us to the upcoming meetings. We have some meetings planned for the rest of the year. Next month, I'm really excited to talk about how you get undergrads involved in your research. We really are looking for volunteers that want to talk about how they have experienced success with undergrad research, how they pay for undergrads to participate in research, or any other advice you may have for us. And then in December, we're going to have a later meeting where we hold a holiday social. And I believe it will still be very early for our Aussie crowd, but we're hoping they can sign in as well. So next month, what we're hoping to talk about is really how you have gotten undergrads involved in academia or in your company. We are interested in sharing mentorship tips, project results, any available internships so we could get the word out there. We are interested in hearing about undergraduate experience in research or anything else that you might think is fitting for this meeting. There's a Google Doc link on the email that announced this meeting, or you can always email the IWB account and they can get a hold of us. So today, our meeting really focuses on learning more about the research that's going on in our group. I have a couple presentations that have been recorded from members who are just not in the time zone that works with this meeting. And we'll save those videos for end. What we're going to do is start out this meeting by learning more about Danielle Siegel's work. She's from the Boise Applied Biomechanics of Infants Laboratory, and her title is Get Rolling, Muscle Activation and Coordinated Movements of Infant Rolling. And Danielle, you might have to give me just a second to make you co-host so you can share your screen.
Okay, no problem.
Okay, go ahead.
Okay. Okay, so thank you for that introduction. So yeah, I'll be talking today about muscle activation and coordinated movements of infant rolling. And I'd like to acknowledge all my co-authors who really helped with this project and make it possible as well. Maybe go for it. Okay, so to begin, we first have to understand what is rolling. Especially for babies. So rolling is the complete movement that begins in a supine position and ends in a prone position and vice versa. So baby rolling from their back to their tummy or from their tummy to their back. Rolling's also a key motor skill and an important developmental milestone. This means that pediatricians, parents are watching out for rolling to make sure that a baby's development as expected. What we currently know about rolling is that active rolling promotes healthy brain and motor development. And to initiate and complete a roll, infants must use whole body goal-oriented movements. That means that they are having to have some sort of coordination and muscle activation to achieve these movements. From a biomechanics perspective, what we know about rolling is actually not that much. So a previous study did find that there was 6 different coordinated movements that babies use to achieve a roll. These are shown here in these 6 different pictures. So if you can imagine, all these babies are rolling to their left or to the right side of our screen. The white limbs that are marked with an asterisk, those are stationary throughout the roll. So they're basically there to provide some sort of support and stability as the baby's rolling. The darker colored gray limbs initiate the roll, and then the lighter colored gray limbs follow after the roll has already been completed. So even though this research has found these 6 different coordinated movements, no previous studies have explored how these coordinated movements are related to muscle activation. And that's where my research comes in, where the purpose is to characterize the muscle activation and coordinated movements of infant rolling. So how do we do this? Well, we had 38 healthy babies come into our lab for part of our IRB approved study. We wanted to have them roll and be able to categorize their rolling based on those different coordinated movements that have already been established, and then understand their muscle activation for each of these different movements. So we use DELSIS electromyography or EMG sensors to measure their little muscle activation on their limbs. We used a pulse oximeter to just ensure safety during testing. And then we used a GoPro camera to ensure or to record them rolling so we could look back later and determine the different coordinated movements that they used. So we had a baby lie flat on their back for 5 minutes or until they achieved a roll. And we really wanted to look at the initial part of the roll. So we ended up truncating our data to the supine to lateral rotation, or like a halfway point to the roll. And if a baby didn't achieve at least one of these within the 5-minute time period, they were just excluded from our study. And that left us with 24 healthy babies, about 6.7 months in age, who achieved one of those rolls for us. So here's a little video, hopefully you guys can see it, of this baby achieving a roll type. So this was the first thing that we did for part of our analysis, was to look at all these videos and see which coordinated movement they use. So if you look at that arm that they're rolling towards, you can see it's pretty stationary. It's not doing much. It's really there for support. And the other 3 limbs are working together to initiate that roll. Then for the muscle activation, we narrowed it down to 4 different muscle groups that we thought really encapsulated the different rolling movements. Those were the abdominal muscles, the erector spinae or back muscles, the quadriceps, and the hamstrings. So moving into our results, we were really lucky to see all of the 6 different coordinated movements for babies rolling in our lab, and we saw 72 of them. So we have a pretty good set of babies rolling. This pie chart shows the % of those total rolling movements for each of the 6 different kinds. And there's 3 in particular that are kind of important to note. The first one is coordinated movement A. We saw the least of this one at only 6.9%. And then C and F were tied for the most at 26.4%. We kind of believe that we didn't see an even spread of these different roll types because of our limited age range that we had in our lab. And these are kind of expected to change with time. Moving into activation results, we're going to dive a little bit closer into these graphs in a little bit, but to kind of understand how we got here is that we use MATLAB to filter the EMG data, and we normalized it to a 5-second resting period for the babies, and then we categorized the data by muscle group and coordinated movement, and then calculated the mean at each time point throughout the rolling movement and represented it as a % of the maximum muscle activation. So that x-axis is the % over the roll, and the y is the % of the maximum muscle activation. We then kind of found these thresholds where the green region is a low region of muscle activation, the yellow is a moderate, and then the red is a high level of muscle activation throughout these roll types. So we're starting with coordinated movement A. We can see at the beginning half of this roll, babies are really initiating and recruiting all their muscles to achieve this roll type, and definitely in a moderate region. For coordinated movement D, this one, or B, excuse me, has a lot of axial rotation and twisting happening, which is matched with this high erector spinae muscles that we can see in blue on this graph. There's a lot of twisting happening, so it makes sense why we're seeing that. For coordinated movement C, this one has flexion and crunching motion happening to achieve this roll type, and this is matched with the high abdominals and quadriceps that we see in yellow and purple in this graph. Moving on to coordinated movement D, the babies are also really recruiting all their muscles in this roll type. There's a lot of different movements happening, especially through the second half of the roll. And then for coordinated movement E, again, this one has some axial rotation happening, and we can match that again with the erector spinae being one of the most used muscle groups. And if we look back, we can compare that to coordinated movement B. If you look at these 2 different roll types, the only difference is that stationary arm. You can see similar trends between the erector spinae muscles throughout this roll type. And then finally, for coordinated movement F, this one again has some high flexion and crunching motion happening, and we see high abdominals and quadriceps. And comparing it back to C, where the only difference is that stationary arm, we see similar trends between the quadriceps and the abdominal muscles. So ultimately, these results really indicate a promising approach towards quantifying the coordinated movements of infant rolls using a combination of video and EMG. No one's really looked at the muscle activation of how babies are achieving a roll with these different movements. So just comparing their movements and seeing like trends that make sense to us is a really great first step. The big impact is understanding how healthy infants achieve a roll is vital in determining key product design features needed to create safe infant products and to understand healthy motor development. We are always looking for participants in our lab. The actual next step we've been working on in this project is to do at-home video survey, so you can do it from anywhere. So if you have a baby who has rolling but is not walking yet, we'd love to have you participate in our survey. It's about 10 to 15 minutes. You can scan the QR code, or you can always email me and I can send you that link. And then if you know somebody who's in the area, we always have studies happening in our lab as well that are in person. So with that, I'd like to say thank you.
Great. Thanks so much, Danielle. If anyone has any questions for Danielle, please post them in the chat. We have about 5 minutes to go through questions after each speaker. Looks like we have a couple questions. Abby says, what age are babies expected to complete the roll milestone, and how does this compare in the age of the babies in your study?
Yeah, so to complete a roll, it's actually a really wide age range. The average is usually between 4 to 6 months, but you can see it much later in life as well, like up to like the 9-month mark as well. So part of our requirements for our study was that a baby must have achieved at least 2 independent rolls at home before they came in. So that's why most of our age range is about that 6.5-month mark to get babies in. So that's when they begin rolling most of the time consistently. So
very interesting. I have a 4-month-old at home, so I'm waiting for those milestones myself.
yeah.
Let's see. The next question is, Lauren says, did the infants always use the same roll strategy? How do you think the infants chose their roll strategy?
So they didn't always use the roll strategy. So it was really interesting to kind of have a baby in. They would, so sometimes we would get those halfway completed rolls before they would achieve a complete roll. You could see their rolling strategy kind of change until they achieved that complete roll. So they were figuring it out themselves, which one worked best to achieve that roll. And from previous research and what we've seen, it does change based on age. Younger infants really need more support, so they'll have more stationary limbs to achieve that roll, where older infants will be able to kind of use all their limbs to roll over. Yeah.
Okay, great. And then Kayla asks a follow-up question. She wants to know if there's any difference in roll coordination if they roll to their left or right. Do infants show a roll side preference?
So we didn't look at the differences between the right and left side. We actually codified our limbs so we could compare both directions of rolls for the study and have a kind of larger data set. We did ask parents when they came in, is there a preference in which your baby likes to roll? Because it is seen that, they'll start rolling one way before they start rolling the other. So they do have a preference. We really didn't take that into account. We were just hoping for them to roll, because it's kind of hard to get babies to do what you want when you want them to do it. So
yes. Okay, and then Laura Ann asks, she says, thanks for a great presentation. Tummy time is recommended in Irish and UK healthcare systems as a way of strengthening baby's core. I'm not sure how much this is recommended in the US. It is. But do you have any idea how this could contribute to rolling strategies baby use? I have a 5-month-old here who loves rolling.
So I don't know how much it changes. I mean, the more tummy time, the more like abdominal muscles and back muscles and different things that they're gaining to develop. And so I would say that it probably does have an impact on what they choose. Because as babies are getting stronger, they are going to choose different strategies that they find easier. It's very similar to like adults, how you choose the easiest path when you're trying to accomplish something. So that's the same way that would happen with babies as well.
Great. Thanks so much, Danielle. Do you have any closing thoughts or advice for us on baby data collections before you leave?
It's really fun. It has its own unique challenges because we are working with very tiny little humans, but yeah, it's been a great experience and I enjoy it. So
it looks like a great setup.
Mm-hmm. Okay,
great. So Erica, we're going to go with your presentation next. Erica Bell is from Mayo Clinic, and her title is the unique insight of subject-specific imaging, which I know is a topic that all of us are very interested in.
All right. Hi. Good morning, everyone, or afternoon, evening, wherever we're at. So I'm going to do more of kind of like an overview. I use subject-specific imaging in a lot of the work that I do. So instead of talking about one specific project, I figured I'd just kind of talk about it as a topic itself about how I use this imaging in my work. So I would quickly say that, can I get rid of these controls? They're like in my way. There we go. Okay. So I've done a lot of research throughout my undergrad, graduate, and postdoctoral time, all of them kind of involving this subject-specific imaging. So most of what I've done in my undergraduate and graduate work is actually in feet. I've done some things with running as well, as you can see in my undergrad study. But most of what I use in my subject-specific imaging throughout my undergraduate and graduate time is in ultrasound elastography. And I've also done some work with planar pressures, 3D motion capture, and a couple other methods, but I'm going to focus on the subject-specific imaging. So the basis of a lot of my undergraduate and graduate work, like I said, revolved around feet. And the idea is that most of the modeling that is produced for the feet is not so specific. So a lot of what we see, and this is an MRI image, we're thinking about looking at the muscles and tendons that are in the feet and how we can model those to help us better understand, one, how the foot functions, but also how these muscles and tendons might be contributing to injury mechanisms and how they happen, how we recover from injury, and things like that. But as you can see here in this MRI image, this is probably like the plantar fascia. You probably have a couple of different muscles in here, but you can't really see any distinctions between that soft tissue imaging. It kind of comes in as one lump. And that's how a lot of modeling of the feet happen as well, is that these soft tissues are modeled kind of as just a lump, basic soft tissue, but there's no distinction between fascia and ligaments and muscles and things of that sort. So we know that we have lots of muscles, tendons, things going on in the feet. It's actually a pretty complex system in the foot. And so the goal that I had with all the work that I was doing during my graduate and undergraduate time was just to find the link. What is the link between what we see that's going on in the foot and how these individual muscles, tendons, and ligaments may be contributing? So the big part of what my dissertation work, and that's most of what I'll be presenting today, is to understand the separate contributions that each of these structures can have to overall foot function, and then with ultrasound elastography in particular, how stiffening of these structures or changes to the material properties of these structures can affect foot function. And this gives us a better understanding, as I mentioned, of injury mechanisms, potentially helping us with injury diagnosis, and then developing potentially new or improved treatment interventions. So I'm going to kind of run through these studies very quickly, but just to give a brief methods overview. So we talked about this, trying to look at individual structures. So I use a lot of ultrasound shear wave elastography. I'm not going to get too nitty gritty in on what that is, but basically it allows us to look at structures in vivo. This is a highly subject specific way to look at things because it's very quick. You can learn the technique for looking at muscles and tendons in the feet using ultrasound relatively quickly. So it's a very short training time. And it allows us to look at individual structures. And in addition to getting material property measures from ultrasound elastography, we can also get some architectural measures. So material property wise, if I want to explain that very quickly, is basically that this ultrasound transducer here that I'm holding sends a pulse into the tissues, and it generates basically a wave in the tissue. And then how fast that pulse comes back to the ultrasound introducer indicates some stiffness of the structure. So the faster it comes back, the stiffer the structure is, and the slower that signal comes back, then the less stiff it is. And it gives us this image that we see on the screen. We can see it in real time and also go back and do image acquisitions over a certain amount of time. And then we can go back in with a tool that's embedded in the ultrasound machine itself to actually put some quantitative numbers based on whatever region of interest we're trying to look at. So this is a muscle in particular. I've also used some planar pressure mapping in some of the studies that I've done, and like I said, 3D motion capture, but that's not the focus of today. So I'm going to try to quickly run through these. So I did my first study in undergrad was with runner's feet. I am a runner. I was on the track team, so that's how I got pulled into this work. This is a paper that we actually have out. And the idea really was to look at the material properties of intrinsic foot structures in runners who had experience in minimalist running shoes, which was a big rage when I was still in college, and then traditionally shod runners. So our main findings from that was that there was really no stiffening associated with wearing minimalist shoes. And the flexor hallucis brevis, which is the flexor of the big toe, we actually found to be stiffer in those who ran in traditional running shoes compared to minimalist runners. We looked a little bit into what could potentially explain this and relationship-wise, and we did find a moderate positive relationship between training load, so the mileage that people were running per week, and this, and I think tendon stiffness, which may suggest some strengthening of tendon when running in traditional shoes, but additional work would need to be done in order to really make that link. So the impact of this is that increased loading on structures, on these individual structures that we have in the feet, without necessarily resulting in stronger tissues, may actually increase injury risk as opposed to reducing it, which was highly advertised in minimalist shoe running. The dissertation portion of the work I did was mostly dealing with diabetic feet, and not to gross anyone out, so we didn't do any real pictures, but basically diabetics can suffer from ulcers. It's up to 25%, I think, of all diabetics have that risk of developing an ulcer sometime during their life. And the idea is that this is the proposed mechanism for how mechanically how these ulcers can develop. So there are some physiological factors that come in, but the basic, what we were trying to look at was, again, the stiffening of soft tissues. And it's been suggested that stiffening of the muscles and tendons in the feet reduce range of motion at the first metatarsal phalangeal joint in particular. So this may be a cause for why these ulcers are developing, because stiffening of these tissues leads to some elevated stresses in the plantar tissue during load bearing. So it's not dissipating as well as it should, like in a normal healthy foot. And this again leads to these high plantar pressures. So the big goal of my study was to look and see if we could find a relationship between stiffness of these foot structures and plantar pressures during gait in diabetic individuals. I know some people care about demographics, so those are here for you if you care to look at those, but I'm not going to get into that. Our main findings were that we found greater stiffness at multiple structures in diabetics compared to controls, but there's a very large variability. So as you can see in these box plots here, a lot of our diabetic individuals are in the range of what our controls are, but we do have some very distinct outliers. And we believe that there's something different about this group, and they could be the group that is more prone to developing ulcers or having some of those issues, but we're still kind of trying to think about and tease out what is so different about them that their stiffness is so much higher. Interestingly, we also found that there's a decreased stiffness of muscles and tendons, which we did not expect. And so we think that stiffness of musculature and foot soft tissue in diabetics warrants a little bit more study, because it's not as straightforward as higher stiffness equals higher pressure as we once thought. To look at that a little bit more, we also looked at plantar fasciitis because it's the opposite. So it's been said that a lower stiffness is associated with people with plantar fasciitis, and that is part of the injury mechanism. Again, I have demographics up in the top right, and we use ultrasound elastography again just to look and see what was going on. So in our symptomatic group, they had substantially lower stiffness of their plantar fascia than both our asymptomatic group. So this is people who have plantar fasciitis, like a history of it, but they weren't currently symptomatic. And then our controls who have never had plantar fasciitis. There's also a high variability in the stiffness along the plantar fascia. So we measured at a proximal point closer to the toes, closer to the heel, and then at a distal point closer to the toes. And you can see these percent differences show that there is some differentiation there as well. We also we did this with PT people, so we also looked at this relationship between some of the clinical measures that they do in clinic, and we found some interesting relationships here. Control is in A, symptomatic is in B, and asymptomatic is in C. And if you see, the relationship between asymptomatic and control are in the same direction, but we have a total opposite direction for our symptomatic. That's interesting, and we still don't know why. And we're looking into that as well as we're preparing manuscripts for this work. So we think ultrasound elastography could potentially be useful in diagnosing or monitoring recovery in patients with plantar fasciitis, because it kind of seems like this stiffness may be rescued in our asymptomatic people that is more close to what we're seeing in our control individuals. I think I'm gonna have to stop there because I think I'm about at my 10-minute limit. So I'm gonna skip what I'm doing in my postdoc work for now. And I'm just gonna conclude with that and say thank you to make sure that we stay on time, and always gonna plug my Black Biomex group.
Thank you, Erica. If anyone has any questions, please put them in chat. I do have a statement that says minimalist shoe running used for regular strength training is still very much being pushed by some large names in the fitness industry.
Yes, it is. And I will just say, and hopefully nobody comes at my neck for it, but I just think there's not enough research out there for us to still be making said claims. Not such a strong claim to that. I think we still need to do some more research work in that area. Coming from a runner myself.
Any questions? Okay, well, moving on, no questions.
I have
right
a question,
now.
Erica.
Oh, there you go.
What do you think the best thing you can do is to prevent injuries like plantar fasciitis?
That's a great question. Honestly, so we've kind of been looking at this as we're trying to hammer out our discussion into what this might look like and how that informs us about treatments and things. I honestly think it might be different. I don't think the same type of treatment is going to work for everyone. And that's a weird thing to say, but I think it's true. I think some people benefit from some of the strengthening exercises that can be done. I think some people benefit from the stretching of the plantar fascia. Some people benefit from just taking some rest. Others find insoles to be helpful, while others say they don't help at all. So I think it's really across the board, and I think it's very subjective based on the person. How we can maybe make that more specific and scientific to say these type of people respond to this treatment and these type of people respond to that treatment. I'm not really sure what that looks like, but that would be something interesting to maybe try to tease out at some point.
Okay. Here we do have some questions coming in, Erica. Is there a trend towards training and stiffness sprinters versus high mileage?
That's a great question. I haven't really looked in sprinters much because, like you said, these are more long distance runners, and sprinters, funnily enough, also use more minimalist shoes, especially when they're racing, not necessarily when they're training. Well, I guess when they're training too, because you got to train in your spikes as well. But I am not sure, because with sprinters, they're not going to be doing so much high mileage. So theirs is probably more of an acute response as opposed to more of a chronic response that we might be seeing in our higher mileage or our distance runners. So I can't really speak to if I can see a trend between those two different groups.
Another one is from Lauren. Great talk. I might have missed it, but were there more regional variation in stiffness in those with plantar fasciitis than those without?
That's a great question. I actually wonder, can I look at that in my numbers that I had on the slide? I don't think that's something that we looked into directly. They seem to, well, it's kind of hard to say because the symptomatic group was so much lower. But I would say, I mean, it was a substantial difference for all of the groups when you looked at their distal versus their proximal. So the one closer to the heel or closer to the toe, there was a substantial difference. Like some of them dropped by almost like half. So I think it's very variable, but there's I don't know between the groups who had more of a drop, because that wasn't something that we directly looked at, but that's a great question and we should look at that.
And do you have a hard time using ultrasound on such small foot muscles?
That's a great question. So it's interesting because the probe that we use is not that big. So like on my hand, I think the probe is probably about this long. So, and you're only getting, the probe is small enough for what we're measuring. So but some of the muscles or tendon, like I would say muscles in particular, like the abductor hallucis, for instance, or which runs kind of like along the side of your foot, you can get almost like the whole muscle belly in one field of view, but you miss its whole tendon because that runs off somewhere else. So it depends on what muscle you're looking at. It's actually not as difficult as you think it is. You just have to be mindful that you may be getting a whole muscle, or you may only be getting a portion of that muscle, because they tend to run kind of long and have very long tendons. So good question.
2 more questions, and then we can go. I might have missed this, and I asked this with a disclaimer. I have used elastic myself. How can you standardize the pressure applied to tissues? Could this impact the measured shear modulus?
Good question. So this is shear wave elastography, not like compression elastography is another one, I guess, that people use, and that does involve actually putting a pressure on there. With shear wave, I don't know if there's a way that you can standardize. Maybe there is, but in my experience, there was not a way to standardize it. You had to be very mindful of how much pressure you were putting on the probe. So really as lightly as you could hold the probe on their foot, because if you push down, you'll see it. Like you'll easily be able to see that it'll saturate close to the top of where you're measuring if you're pushing too hard. So I think visually we can tell, and you just have to pay attention to how much pressure you're putting on there. But standardizing, I'm not sure. I'm not familiar if there's a way to do that, but we weren't able to do that.
Okay. And in the presentation of the run and footwear research you did, you mentioned you mentioned the stiffer structures are stronger. Does that apply to all types of structure?
Great question. Off the top of my head, I want to say it depends. I was going to say no, but I'm going to say it depends. So I think, honestly, for whatever structure you're looking at, I think there is a range, like a good range or a healthy range you want to say that you want to be in. And I think if you're on either side of that, if you're less stiff, or if you're on the other side and you're too stiff, that's when you start to run into problems. Currently, I don't think there's any research out there that's been done to kind of look at what a normative data set would look like. So what that kind of healthy range would be, or normal range would be, for stiffness of different structures. That would be something helpful for someone to do so that we can have that reference. But I think it definitely does. It's going to change based on what structure you're looking at, because tendons are much stiffer than muscles. So that range is going to look totally different than what it's going to look like for muscle. And so on. So more stiff does not always mean stronger. Sometimes more stiff can mean problems. So I think it all depends on the structure you're looking at. And I think it also depends on the context of what population you're looking at. If it's an injury population, healthy population, or whatever. I think there's a couple of distinctions that need to be made before you say strong equals stiff or stiff equals strong.
Okay. Thanks, Erica, for that. If y'all have any more questions for Erica, you can please either send them to her directly or send them to us, and we'll make sure she get them. Next, we have Jenna Barnett from the Neomechanics Research Core at the University of Maryland College Park. Residual limb loading with a lifetime of osseointegrated prosthetics used in individuals with a unilateral transfemoral amputation. A little bit of tongue twister for me, being from Mississippi, but I got there. So Jenna, you have co-host abilities, and you should be able to share your screener.
All right, perfect. Well, thanks for having me so I can give this little mini practice talk for my dissertation. All right, let me make sure this isn't going to be in the way. Okay, so as was just introduced, I'm going to talk about residual limb loading with a lifetime of osseointegrated prosthesis use in individuals with a unilateral transfemoral amputation. Let's see. There we go. Okay, so in terms of background, osseointegration or bone anchoring of prosthesis is kind of a new and alternative method for prosthesis attachment. Most of the time when people talk about attaching a prosthesis to the body, they talk about the socket-based, which is in this left picture over here. And you can see the socket kind of in that grayed out region around the residual limb. And then you can go through surgery similar to how you do a hip implant or a tooth implant, and you get a titanium implant put into your femur, which the bone then grows into and fixes that titanium to the body. It ostensibly increases the function for lower extremity amputees in terms of oxygen consumption, the 6-minute walk test, and timed up and go. Those get the performance on those different tasks increase when compared to using a socket-based prosthesis. And there are some gait characteristics, in particular on the hip, which change to increase functionality as well after the fixation surgery and rehab. While there is these functional increases, there is some risk that due to the direct connection to the skeletal system, the contact with the ground or any sort of force that's put on the prosthesis may travel up through the different components and then into the tissue of the residual limb with minimal damping. There have been a few studies that have looked at the stress on the bone using finite element modeling to see if there's any sort of traumatic injury that could develop. But these studies have really only looked at walking at a single self-selected speed, finding that it's not outside, the bone strain isn't outside of normal ranges, but there may be a relatively low safety factor for the bone. One thing that has not really been studied at all with this population is the effect of walking speed. So we know the general understanding is that when you increase your walking speed, your ground reaction force will increase as well, which may lead to the transfer of higher forces into the bone as these amputees become more functional and begin to walk faster or want to participate in other higher intensity activities like sports. And so that's kind of where my dissertation comes in. There's a lot of words on this slide, so I'll go through it really quickly. I'm aiming to investigate the loading on the residual limb of individuals who use an OI prosthesis at different anatomical levels. In particular, the ground reaction force, the joints, the prosthesis bone interface, and the residual limb bone itself, while they walk at multiple speeds to determine, these are my 3 specific aims that I currently have for my dissertation, whether using an OI prosthesis over a lifetime may result in cumulative injury risk to the bone surrounding the implant, whether the OI prosthesis actually changes the intact limb reliance, which is seen in a lot of socket-based amputees, and whether using an OI prosthesis changes the joint kinetics and kinematics during walking. What I'm going to talk about for my prelim results in a second is focusing on these first 2 specific aims. To give you some methods and kind of what I'm going to use to study this. For my first specific aim, looking at the lifetime use for osseointegrated prosthesis use. I'm going to do some kinetic analysis, and then I am building a finite element model of the bone implant system, and then I'm going to take the stress and the strain from the loaded model to do a probabilistic injury model, which basically will look at what's the probability of an injury over X number of loading cycles over time. And then for this second specific aim, that's going to use more traditional gait analysis and inverse dynamics, where I will look at the ground reaction force between the 2 limbs. So here's a video of one of our participants. We've had 3 participants come in. They're all relatively high transfemoral amputees. We have them walk through the motion capture space while we're collecting the ground reaction force, the motion capture, and then if you look at the prosthesis, you can see this little box with markers on it. That's a load transducer that we've placed in the prosthesis system to get the forces as close to the abutment or the external part of the implant as we can get it. For my prelim results that I currently have for the first specific aim, I have 3 different things that are going to be output. The first is the bone stress and the strain. On the left, you can see my initial model that I have for the bone with the implant inside of it loaded at the bottom with some validation loads right now to see what the stress and the strain looks like. And right now what it's showing is that there's high stress or higher stress and strain up here closer to the greater trochanter. but it's not necessarily at a level that is outside of the normal range for bone. And then on the right side, what I have is I'm showing the average force from the IPEC, or that load transducer in the prosthesis system, while they walked at 3 different speeds. So the red line is the self-selected walking, which is just a normal, whatever their comfortable walking speed is. They walked at a faster speed, again, subjective to them. So we didn't necessarily do a specific walking speed and then a slower subjective walking speed as well. The interesting thing about this figure is that you're not necessarily seeing that speed force relationship that I would have potentially expected. The slow and the normal self-selected walking speed seem to be relatively similar, and then the faster walking speed decreases slightly. Keep in mind, this is only with 3 participants, and so it's a very low sample size, and it's still the prelim results. So this relationship or lack of relationship between speed and force may not be maintained as we continue doing our analysis. But one potential thing that may be the reason for that drop with the faster walking speed is that they still rely on their intact limb at the fastest walking speed for additional motion generation. That will hopefully be figured out as I keep doing my analysis. And then for the second specific aim, I have the ground reaction force on both the amputated limb and the intact limb. Talk about the intact limb first. So you can clearly see that speed ground reaction force relationship, where from the slow, the normal, and then the faster walking speed, you're increasing the 2 peaked ground reaction force. But you don't necessarily see that similar to the force of the abutment on the residual limb with the amputated limb. Instead, we have that drop in the force on the faster speed, the slightly lower force at the slow speed, and the highest force being experienced during the self-selected or normal walking speed. Again, that could be due to them transferring the additional motion generation to the intact limb during their fastest walking speed, or it could be due to something else, such as them changing the contribution of joint moments or joint kinetics. And so that's kind of where my third specific aim is eventually going to go towards, is trying to figure out why we don't necessarily see that speed force relationship. And then for a second outcome that I'm potentially exploring right now is looking at the symmetry between the limbs for the ground reaction force and the joint kinetics and kinematics. And so I put the both limb ground reaction force on the same figure, so you can kind of see when it's normalized across stance phase how it compares. And then calculated a symmetry index using a symmetry function to see what the difference is currently between the limbs. And obviously you can see the trends both in the figure and on the symmetry index, where there's high asymmetries early on and later on in the stance phase. In general, most people, when they use a symmetry index like this, 5% either way is considered, less than 5% is considered symmetric, and anything above 5% is considered asymmetric. And so it appears there may be some high asymmetry still occurring early on in stance and late in stance across all walking speeds. And so just to sum it all up, my prelim points of interest, the force at the abutment or at the end of the implant may be similar across subjective self-selected walking speeds, indicating there might be some sort of protective mechanism, or as they increase walking speed that they're still relying on their intact limb for that additional motion. But the intact limb does show that expected speed ground reaction force relationship, while the residual limb may not. And then finally, the prelim results indicate the ground reaction force may be similar between limbs at the normal self-selected walking speed, but that may not be true across the walking speed. So the peaks may be similar, but that when you look across the walking speed at the normalized stance, that there may be some high asymmetries, or there may be some timing shifts in where they're generating their peak forces. So here are my references. Then I want to say thank you to all the people in my lab, my dissertation committee, everyone that has been helping me with this research. Questions, thoughts, concerns?
Great. Thanks so much, Jenna. What I'll do is I'll read your questions for you. It looks like Maria Pascal says, great presentation. One thing not mentioned is that the socket-based prosthetic users are very susceptible to pressure ulcers. I imagine that the general tissue health is much less of a concern in these OI users, correct? Also, will you look at the force and the prosthesis of standard socket users to compare how this differs in the prostheses?
Okay, so let me pull that open just so, since that was a little long, so I can just make sure I answer everything. Okay, so hi Maria, great question. General tissue health really is not that much of a concern for OI users. It is a little bit since the bone implant does extend out of the tissue and the skin, so there can be some issues around where that implant extends out if the surgery isn't done well or if they do something to irritate that area. But in general, they don't really experience any like ulcers or like pressure sensitive areas. And as to your second question, I'm not necessarily going to collect socket-based amputees, but there are some studies out there that do have some normalized data for socket amputees. And so I'm going to kind of use that as like a reference to see what the differences might be or if there are some differences.
Okay, great. Next question is there anything in the horizontal component of the reaction forces that may give insights on how the limb as a system is controlled at the ankle, knee, hip as a team?
So I haven't really looked at that yet. I'm working my way towards that right now. And so I am really curious to see how the ankle, knee, and hip work together as a team to generate the motion, but I have not looked at that at all yet.
Okay, next question is great from Julia, who also does OI research. She says, how familiar were your subjects with their prosthesis systems time since implantation? Were you able to collect these data pre-implant? If so, how do these data compare pre-post?
Hi, Julia. So all of our amputees are at least 1 year post-rehab. I think the farthest out from the OI surgery that we've gotten, one participant was, I want to say 3 years post-OI surgery and rehab. And then the closest we've gotten was just over 1 year post-rehab. And so they're all relatively close to, just because it's such a new technology, there's not a lot of people that have had it for long periods of time. But they all have been very functional and very fit, honestly. We did not collect any data pre-implantation, unfortunately. I would love to do that, but that would make my dissertation like 10 years long.
Okay, and then the last question, just due to some time constraints, is again, super presentation, Jenna, really novel seeing this data from Laura Ann. She says, what was the bone quality of this individual to start with? Do you happen to know what their bone density was, and could that affect the calculated force and force distribution?
Yeah, so we didn't measure their bone density, and I don't personally know their bone density, but they do go through a 6-month rehab process where they do a gradual overloading of the bone to build up that bone density. And there are a few studies out. I think I've seen 2 or 3 that have looked at how the bone density is changed with that rehab process and found that the bone quality gets much better as they go through that rehab process. And that's not necessarily something that is a concern where they're going to, you know, take a couple steps and have a traumatic fracture where their bone just completely separates. And so that's why I'm more interested in that gradual overload with the cumulative injury over time, that probability model.
Great, thanks so much, Jenna. Everyone, I've included Jenna's Twitter handle in the chat, so feel free to reach out to her if you have more interest in her project. Next up, we're going to have Lauren Welta from the University of Wisconsin-Madison, and her title is Mobility of the Human Foot's Medial Arch Enables Upright Bipedal Locomotion Foot Function. Thanks, Lauren.
Awesome. Thanks so much for having me. So this is some research that I did during my PhD, and so it was done at Queen's University, so that's why it doesn't match the University of Wisconsin-Madison, but that's where I'm doing my postdoc right now. So today I'm going to be talking about how the mobility of the human foot enables us to walk upright. So the primary motivating question that I had was, why does the arch recoil? So we have this spring-like arch that deforms in early stance and then springs back or recoils in late stance. And it seems to be important when we restrict arch deformation, it leads to an increase in metabolic costs, suggesting that having an arch that recoils allows us to move more efficiently. However, the reason why the arch is allowing us to have this more efficient motion is unclear. In running, we often model the leg as a spring. And so we thought maybe the arch is contributing to this spring-like motion. Maybe it's helping to propel the center of mass. And so in this leg spring, we have the knee, we have the foot ankle, and we have the shoe ground, among other compliance in the system. And so maybe this foot is contributing to this spring-like propulsion. So when we actually break it down and we look at, okay, so we have this whole leg, we have a knee, we have foot ankle, the shoe ground. What can the actual contribution be for the foot to lift the center of mass in propulsion? So if we think about it as a certain length, we have the mid-stance height of the arch. And then we have the triceps surae and the calf muscles that are lifting the foot. And so we have some height that we're gaining from that. So from ankle plantar flexion. And then we might have this small amount of motion that's occurring from arch rise. And it didn't really seem like it was possible that it could be contributing that much to center of mass propulsion, and nobody had really tested it. So we went about our way to try and kind of figure out what the contribution could be of arch rise to center of mass propulsion. So we used high-speed biplanar X-ray during walking and running, and kind of in line with Erica's talk, I used subject-specific bone models to measure each subject's individual bone motion in the medial arch. And so on the bottom are examples of what that 3D motion looks like of each of the bones in the medial arch. And to kind of get at whether the arch recoil had a contribution to the center of mass, I mathematically locked the arch together. So if you look on the left, the dark gray arch isn't moving. So basically that motion is locked, and the motion of the toes and the tibio-talar joint, or the tibia relative to the talus, has motion that's consistent with a moving foot. On the right, I've included kind of the levering that happens as a result of the plantar flexors lifting up the arch or lifting up the foot. So I'm going to be comparing between this mathematically rigid arch and then an arch that's allowed to rise. So our expectation was that we had this ankle plantar flexion and a small contribution of arch rise to lift the center of mass. And what actually happened is that the arch was lower when it was allowed to rise, which was highly confusing. So how is this possible? So basically, yeah, for every subject in walking and in running, no matter what, the rigid arch was always higher than the arch that was allowed to rise. And so how is this possible? So as I said before, we had consistent tibio-talar motion. And so relative at the joint, can you see my cursor there? Yeah, okay, sweet. So at the tibio-talar joint, this motion or this relative position is the same, but the tibia is pitched forward here. And so underneath, when the arch is recoiling, it's actually allowing the talus to sit more upright. And so we can achieve this higher tibia posture. And so we wondered what would happen if perhaps we moved the tibia posture to be in the same position as the natural motion that the participants undertook. And we found that when we moved that tibia posture to be more posterior, we actually ran out of joint space. So we basically achieved this biologically infeasible position if we had a rigid arch. And so we wondered, it seemed that this tibia posture push off might be important. And so we said, okay, well, what would happen? When would the foot take off if we looked at just the tibia position? So we locked the tibia into the takeoff position and then looked to see when it was most aligned with the normal motion. And we found that the foot would have to take off substantially earlier and much lower than when the arch was moving normally. And so this suggests that the the plantar flexor muscles would have to activate more quickly and probably in a less optimal force velocity region, and therefore require more energy to be able to take off from this earlier stance time. And interestingly, when we looked just across participants, because we had a range of arch mobilities, we found that the participants who had a less mobile arch took off from a lower position. In other words, as your arch was more mobile, you could take off from a higher position. And so where does this happen in the foot? So we thought primarily it was going to be in the talonavicular joint because it's considered to be one of the more mobile joints. But when we actually broke it down into each of the contributions of plantar flexion for each joint in the arch, we found that most of it's happening at the cranionavicular joint and not really at the talonavicular joint. And so this was really interesting because it was completely unexpected, as most of the study has been. And yeah, so, and this is interesting because it allows us to kind of think about if our arch is allowing us to walk from a more upright position, maybe this has something to do with the evolution of how we came to be walking in an upright position. And maybe this joint, this cranionavicular joint, is an important joint for paleontological analyses to try and look across species, across timelines, to try and understand how we came to walk upright. And so we did a small comparison between chimpanzees' tibial lean position and humans. And so in black, this is basically the position of the tibia in late stance relative to the upright axis. And so we can see, as it kind of expected, humans walk with an upright tibia and chimpanzees walk with a more flexed knee posture, so a more forward leaned tibia. And then I've shown the rigid arch here as well. So in this purple line, this is basically where we lock the arch. And then you kind of approach this more flexed forward posture. And we suspect that it has to do something with the position of the talus. So if we look at the talus bone here, we can recoil and continue to be upright because of the structures in the arch that allow that arch recoil to happen. And we have more arch recoil than chimpanzees do in their foot. And they also have a more forward leaning talus. And so we think that this has something to do with why we kind of select for this tibial lean and might be and the arch mobility in general might be one of the reasons why we're able to walk upright. So in conclusion, arch mobility seems to enable upright walking. And most of that happens at the cranionavicular joint. So I'd like to thank my co-authors, all my funding sources, and this was recently posted as a preprint. So if you want to read the paper, we would love to hear your thoughts, and feel free to contact me at my email or on Twitter, or wherever you like.
Okay, thanks, Lauren, for that presentation. Does anybody have any questions for Lauren? Okay. If you think of a question later, please feel free to message us or message Lauren at her Twitter handle that was posted earlier. Sorry. Oh, wait. And I have posted what a rich data set collection of humans and Japanese.
Oh. I will add a caveat to that I did not collect the chimpanzee data. Our collaborators collected that with motion capture, so it wasn't actually the biplanar was humans, and then that was motion capture.
I mean, I do have questions, but I think all of my questions center around data collection of chimpanzees. so I'm gonna refrain from asking them. Okay, thanks, Lauren. The next presenter up is Joanna Reeves from the University of Bath, and part of her title alone has me having a lot of question marks. Who needs cadavers when you got friends? So research in fine wire EMG. Lauren, you are set up for screen share, so you should be ready to go.
Hi, thanks. Can you see that?
Yes.
Yeah, great. Okay, right. Thanks for the introduction and the opportunity to speak today. So I thought this title might spark a bit of interest, so hopefully become clear by the end. So while I'm currently at the University of Bath, I'm going to talk about some of the research and particularly the methods from projects I've done elsewhere at the University of Salford and the University of Exeter. So my PhD then was looking at the effects of foot orthoses or orthotics on muscle activity and morphology, foot biomechanics, and skin sensitivity. So the sort of orthotics I'm talking about are those with a medial arch support or a medial heel wedge, and they're used to treat conditions such as tibialis posterior tendon dysfunction, plantar fasciitis, and Achilles tendinopathy. And so we know that these orthoses change the way that pressure is distributed on the foot and the external forces, in particular a reduced external eversion moment. But we don't know so much about the internal forces. And one way we can get a sense of what's happening with the internal forces with an intervention like orthotics is by recording EMG. So there's been relatively little research on the effects of orthotics on the tibialis posterior muscle. There's one previous study showing that tibialis posterior activation can reduce with orthotics. So the reason we're particularly interested in the tibialis posterior muscle in the context of foot function and the effect of orthotics is because it's the primary inverter of the foot. So it performs an action that it generates a moment that's sort of similar to what these orthotics would be doing externally. So just in case anyone's not familiar with what inversion looks like, this is inversion at the foot. So the foot sole is rolling inwards. And another function of the tib post is to support the medial arch, which we've just been hearing about. So this is the muscle here from this image from Visual 3D, so Visual 3D, Anatomy TV. And you can see in this other image how deep it is within the shank. So it's one of the deepest muscles of the lower limb, around 3 centimeters deep on average. So this means we need to use fine wire EMG, not surface EMG, to record from this muscle, and hence that can be quite challenging. So when I was learning this technique during my PhD, I consulted a researcher, Ruth Barn in Scotland, who'd used the technique before, and she told me that when she was practicing, she practiced a lot on cadavers, and she said to me, well, you might not have access to cadavers, but who needs cadavers when you've got friends? So you can just practice on your friends. So I thought that's a great quote, and I put it in my acknowledgements in my PhD thesis. So it's also a nod to how grateful I am to participants throughout my research career, especially doing something invasive like fine wire EMG. So just to explain how challenging this method is, there's a 1 centimeter safety window between the tibia and a neurovascular bundle. So this is from Anatomy TV again. So this is the flexor digitorum muscle on the shank as a superficial muscle. And then below that, you have the tibialis posterior. So you can see it's very thin and it's very close to this path of some blood vessels and a nerve. So there's a number of different ways that we can perform insertion into the tibialis muscle, but a couple of them use ultrasound guidance, whether it's by having the ultrasound probe still on the skin while inserting, or scanning and removing the probe and inserting. But just to illustrate then what an ultrasound image would look like, this is the skin surface here, the top of the image, and the depth is around 5 centimeters. So you can see the tib post is here, and that's about 3 centimeters down. So it's pretty deep below the flexor digitorum longus. And this black shadow here is there's a tibia, and the neurovascular bundle shows up as this like 3-leaf clover of black dots. So you want to avoid these two structures, obviously, and insert within this window there. So pretty challenging. So I performed the technique by scanning with ultrasound and then removing the probe and marking where I'm going to insert. So I would do that, prepare the skin, insert the needle, and then the wires are then protruding from the surface of the skin once the needle's been removed, and then the wires get attached to a spring contact sensor like this one from Dalsys. And so I was able to then collect my study looking at the effect of orthotic geometry on tibialis posterior tendon, on tibialis posterior function, and found that the activity in early stance reduced with both medial arch height and medial wedge, but the reduction was greatest with medial wedging. So this work also relates in part to the postdoc I did as a short-term project at the University of Exeter, where we were looking at the footwear preferences of older adults who play sports like tennis, where there's a change of direction. And so we were doing studies in the lab, biomechanics, but we also wanted to actually engage with the user and find out about their needs that they have for footwear, not just doing research on what we think they need. So part of this was some semi-structured interviews with older adults, and we found in a lot of cases they were saying that they really feel that they need a wide-fitting shoe to play sport in, and a lot of the time they were struggling to find that. So it sort of became apparent that, at least within the UK market, the footwear industry is not doing enough to meet the needs of this group. So this has informed the ongoing work in terms of footwear design, so both having a wide fitting shoe, but also some of the needs around increased cushioning, for example. And the balance of cushioning and width was a problem for some that they were then saying that they're wearing shoes that aren't really designed for their sport in order to get increased cushioning. So running shoes tend to be more cushioned than tennis shoes, and so some of our older adults were telling us they're wearing running shoes to play tennis in, which is then potentially problematic because they might be at increased risk of an ankle sprain because they haven't got that lateral support that comes with shoes designed for change of direction sports. So that's then informed some of the comparisons we've done in the lab as well. So this the lab work and the user experience data went into informing the design of a shoe with our industry partner, and this is an industry partner that prides themselves on making wide-fitting footwear that's sort of suitable for all ages. This is the first time that they were making a shoe designed for leisure use and being more active. So we provided them some feedback on the cushioning based on the plantar pressure data we had, and some of the means of fastening it by suggesting different positions of the eyelets. And then the shoe has gone to market and is apparently selling rather well. And so we're very proud that we've been able to provide something that's sort of working towards keeping the older population more active. So the next steps with this are to sort of tie everything a bit together. So I'm going to be returning to the University of Exeter to do some more work with another industry partner looking at footwear design for older females, and this time incorporate some foot morphology measurements and use some wearables and look at collecting data in the field as well. And then tying that to the tibialis posterior. So we're going to look at comparing younger and older adults EMG activation. So this increased foot width that happens with age, we're not entirely sure why it's happening. So we don't know if it's a reduction in functionality of the tibialis posterior muscle or a combination of different factors. So we want to compare younger and older adults, and also look at those with tibialis posterior tendon dysfunction. So this is a pathology where an acquired flat foot is seen and there's pain in the tendon, and so we can then hopefully compare what healthy older aging looks like and tibialis posterior tendon dysfunction. And the treatment of this condition has been identified as a healthcare priority with the James Lind Alliance, which is an organization that gets together with patients and clinicians to discuss what is considered the most important areas to focus on in healthcare research. So that's all I have. Thank you very much.
Thanks so much, Joanna. That was really great. I know we really enjoyed seeing so many connections between your PhD and your focus right now. Let's see who has questions for you. Anna says, Erin, Lauren, and Joe, you could start a consulting company to the footwear world with all your foot biomechanics expertise. Let's see, Naomi says, could wide-fitting shoes be problematic if they're too wide? This could be a concern for lateral movement sports, but maybe it could be addressed through tighter lacing of the shoes.
Yeah, I mean, it's not necessarily a case that everyone needs wide-fitting shoes. So as you get older, so yeah, it could be too wide. It could be a problem as much as not wide enough. So there is a bit of an argument of going towards personalized footwear and you know, 3D scanning being more available to get something that's a bit more tailored to you, or just having more options as well. But yeah, having the ability to tighten a shoe is very important for the lateral movement sports as well, because we also asked some of our older adults about whether they'd consider wearing a Velcro shoe to play sport in, because sometimes some of the footwear that's sort of marketed towards older adults has Velcro on for ease of getting on and off, but then the participants were concerned that, oh, well, I don't think you better tighten it enough, and that's not safe for sport. So yeah, tighter lacing of the shoes is a good point.
It's very interesting. Do you have that subjective measure for like unactive older adults as well?
If what, sorry, inactive older adults?
Like unfit older adults, do they also prefer the wide shoes?
So the other researchers out there is more in the older that say there's work out of Australia saying that the foot's getting wider with age, so more of the sort of walking based studies. So I think this was the novel side of it coming from the sports perspective. So if you look at it from like the podiatry angle and the older it's more common knowledge, but actually going back to the sporting industry and saying that this is a issue for active older adults.
Interesting. Okay, great. Well, we're going to continue our focus on the foot and ankle with Kayla Seymour from the University of Delaware, and her title is Achilles tendon symptoms and structure in adolescents with heel pain. I just want to say that it's really nice to hear about Kayla and Erica's research. I think you have been very visible in this society, and it's nice to hear more about your specific research. Take it away, Kayla.
Thanks, I appreciate that. Move this out of the way. So, hi everyone. Today I'll be discussing some of my research exploring the Achilles tendon symptoms and structure in adolescents with heel pain. And before I begin, I'd just like to thank my clinical collaborators at the University of Delaware, give a shout out to all my friends and colleagues at the Black Biomechanics Association, and also acknowledge my funding sources. Heel pain during adolescence can be a devastating experience involving months of pain, decreased physical function, and reduced quality of life. Calcaneal apophysitis is the most common diagnosis for adolescent heel pain, affecting 3.7 per 1,000 adolescents in the US. This growth plate disorder of the calcaneus is caused by repeated strain at the Achilles tendon insertion with occasional developments of Achilles tendon pain. Symptoms of calcaneal apophysitis in adolescents can be similar to Achilles tendinopathy in adults. However, unlike adults, adolescents with Achilles tendon pathology may be receiving treatment that significantly reduces their physical activity. We know that one of the risk factors for developing Achilles tendinopathy in adults is Achilles tendon thickening, which is shown in the image here. But the presence of altered tendon structure remains unknown in the adolescent population. And thus the purpose of this investigation was to evaluate Achilles tendon symptoms and structure in adolescents with heel pain. And this work will advance the knowledge of adolescent Achilles tendon involvement in pathologies by distinguishing the Achilles tendon from calcaneal symptoms and tendon structural alterations in adolescents with heel pain. So for the study, we had 12 participants with clinically confirmed heel pain who were recruited for this pilot sample of participants, and we had them measure their physical activity level using the PROMIS Pediatric Physical Activity Short Form, which is a patient-reported outcome measure. And symptom severity was also measured using self-report for Achilles tendon pain on palpation with a scale of 0 to 10, and then also the Visa-A questionnaire, another patient-reported outcome measure. And the Visa-A questionnaire was used to determine which limb was most symptomatic. We also assessed Achilles tendon length, cross-sectional area, and thickness using B-mode ultrasound, which you've seen on some slides prior to mine. And then because we know that there's a difference in how the Achilles tendon grows along its length, the cross-sectional area was measured at the 10, 20, and 30% of its length from the calcaneal insertion. Achilles tendon material properties of shear modulus and viscosity were obtained with continuous shear wave elastography. Erica described shear wave elastography really well, but in contrast to the pulse waves that are sent out from a probe, this technique applies continuous shear waves to the tendon via a mechanical actuator, while ultrasound images are then collected. And these images allow for us to estimate viscoelastic properties, such as the shear modulus and viscosity. So for some demographics, we had participants divided into 3 categories based on the pain location in their most symptomatic limb. The majority of participants had pain at both the calcaneus and the Achilles tendon mid portion. And then there was a dual group. So this dual group that had both pain in both locations was the oldest had the most mid portion pain on palpation and lowest Visa-A score in their most symptomatic limb, which indicates a greater symptom severity. For some of the structural results, so the limb symmetry index values were collected for structural measures. This allows us to compare the degree of change between limbs amongst the groups. So for the tendon size, we have each cross-sectional area, limb symmetry index on the y-axis, and then participant grouping on the x-axis. And what we observed was that the participants with calcaneus only pain had the smallest tendon thickness and cross-sectional area, compared to the participants with Achilles tendon only pain who had the largest tendon thickness and cross-sectional area in their most symptomatic limb. And then looking at the mechanical properties, the LSI or limb symmetry index is on the y-axis again, with dependent variables for each group on the x-axis. So here we can see that participants with calcaneus only pain exhibited the highest shear modulus. The participants with Achilles only pain exhibited the lowest shear modulus and viscosity. And then participants with dual pain exhibited the highest viscosity in their most symptomatic limb. So in this pilot study, 8 out of 12 or 67% of adolescents with heel pain presented Achilles tendon pain and altered tendon structure. And additionally, the Achilles tendon morphology and mechanical properties alterations were frequently observed in adolescents with mid-portion tendon pain. So clinical significance, it may be important to assess Achilles tendon structure in relation to symptoms of heel pain in early years of adolescent maturation. And identifying these Achilles tendon structural alterations in adolescents will help improve our understanding of adolescents to young adult Achilles tendinopathy development. And then ultimately, with the proper injury diagnosis, adolescents with heel pain can receive the appropriate clinical care to maintain their physical activity into adulthood. So thanks for your attention and happy to take any questions.
Thanks, Kayla. If anybody has any questions for Kayla, you can raise your hand and we'll make sure you're unmuted. Caitlin, is that a hand raise or a hand clap?
Just a clap for a great.
All right. I just want to say, y'all, we did not purposely make today the foot workshop, but it seems like everybody who answered the call out for today's speakers are speaking on foot, so it's been great. Anna has a question, which is, does the Achilles tendons grow at the same rate as the triceps serrae muscles in children? I've never thought about this.
So no, it does not grow at the same rate. And we're actually, so part of my dissertation is going to be looking at both the triceps serrae and the Achilles tendon, because the Achilles tendon pretty much solidifies at age 13, whereas you can go on and continue developing and growing your triceps serrae into late adolescence and into adulthood as well.
Great. Thanks so much, Kayla. I think, this meeting is rather long compared to our normal meetings. So as people watch the recording of your presentation, they can also reach out to you with questions.
Sounds good. Thanks.
I want to make sure I didn't miss any speakers live. I believe we just have the 2 recorded presentations from our Aussie members left. What I'm going to do is share my screen and we can watch those presentations. And then if anyone wants to have a discussion after, we can do that.
The first presentation is from Anna Esvito from La Trobe University and the Australian Ballet. And she will be speaking on biomechanics, part of my professional path.
Okay, and give me a thumbs up if you can hear and see this video when I start it, Ro. Thanks so much.
Hello, everyone, and thank you to the International Women in Biomechanics for having me today to share my story on biomechanics, part of my professional path. I am Ana Moraes Azevedo, a Portuguese physiotherapist and a PhD student. I define myself as a curious person, which usually it's a blessing, but sometimes can be a curse, who believes in teamwork. And I'm also a person who likes to travel and explore new worlds and who loves to read. I reckon these personal characteristics have been relevant in the story that I am about to tell you today. So every journey in life always starts with the first step, right? No rocket science. Fortunately, I have been experiencing many different first steps in my life. And one of the first steps that I want to highlight, and which brought me here today, was with no doubt the ballet. So ballet led me to my physiotherapy degree, and these 2 worlds have been intertwined since then. How come? I chose to become a physiotherapist due to ballet, and my clinical experience and also curiosity encouraged me to enroll in my first PhD, which topic was lower extremity biomechanics during single leg landings in professional dancers, to learn more about dancers' biomechanics. Therefore, my first PhD introduced me the backstage of research in biomechanics. Meanwhile, during my first PhD, I earned a Fulbright scholarship, and I spent part of my PhD in the US. Also, thanks to this team. It was such a great professional opportunity to dive into the biomechanics world. So we analyzed professional dancers and non-dancers single leg landings in 3 different directions. And here it is highlighted in yellow, the landing phase, which was the main focus. For that, we used motion capture system, force plate, and EMG. And just for the foot, we had 13 markers, which allowed us to study not only the single, but also the multi-segmented foot. And let me tell you, we had many challenges: recruitment of professional dancers and the management of their schedules, the number of markers in the foot, sweat, the impact of the foot in the ground, and this is just to name a few. But a PhD experience in biomechanics, it's also about that, to overcome many hurdles. This PhD was also an opportunity to explore and at the same time to learn important areas in biomechanics research, to collect, process, and analyze data, QTM, Visual 3D, OpenSim, MATLAB, and SPSS were tools that we used to study the dancers' kinematics and kinetics of the lower extremity, differences between a single and the 3-segmented foot models, and differences between experimental approach and computational modeling. So we started with a wider understanding of the lower extremity and ended up funneling to the foot-ankle complex. Overall, the main findings of this PhD were that professional dancers land with a unique biomechanical strategy that may have advantages to mitigate landing forces and reduce loading rates. For instance, they have a more extended landing posture at initial contact, and they also take advantage of more range of motion during the landing phase. Also, the lateral direction was the most challenging one, and as I said, we compared 2 different foot models that provided a distinctive foot-ankle joint kinematics regardless of the jump landing directions. We also compared Visual 3D and OpenSim, and we found similar findings in sagittal, knee and ankle angles and moments, but not in the hip. So I can say that I definitely acquired and expanded my body of knowledge in biomechanics. And I also had the opportunity to disseminate the findings in national and international journals and conferences. But many pieces of the puzzle were still missing. However, one great outcome of my PhD in biomechanics was the two-way street condition. My clinical work brought meaningful questions and ideas to my research in biomechanics. And the body of knowledge acquired in biomechanics improved and expanded my understanding of my clinical work. In between, there is this tremendous part, which is to translate the findings, and not only to the scientific world, but also to the community. And I truly believe in this linkage between clinical work, research, community. So I continued with questions popping up, particularly related to this functional masterpiece of the body, the foot-ankle complex. And because there is always room to improve, to overcome, and to become a better version of ourselves, I enrolled in a second PhD. Why? Why a second PhD is the question that a lot of people have been asking me in the last months. And to be honest, I could spend hours talking about this. But for now, long story short, it was because of the project. The foot is such a challenging and intricate structure and often overlooked. And I would have the opportunity to go beyond the biomechanics of the foot. And also because of the team, the opportunity to work with clinician researchers worldwide renowned. Therefore, in 2020, I was selected to do my second PhD down under, which is a partnership between La Trobe University and Australian Ballet. However, and because of the pandemics, the commencement date was postponed many times. But finally, early this year, I came to Australia to embrace this opportunity, to learn new skills, and to further understand the foot. And let me tell you, I am deeply fascinated about the foot evolution, its anatomical variability, its complexity and function, and at the same time, how little we know about it. After gaining knowledge about the foot as a multi-segmented structure, now I want to explore other avenues. I am here studying the foot morphology and its relationship to pain, function, and performance in dancers, runners, and general population. Yes, it is a big project that involves ultrasound, MRI, force plate, dynamometry, ROMs, and other stuff. But I am just starting, and this is my first semester here, and I still have a lot to learn and accomplish, which means more to come in a near future. What I usually say to myself is take the risk, because only those who risk going too far can possibly find out how far one can go. We just need to take the first step and then embrace the adventure. In my case, the PhD experiences, living abroad in different countries and even different continents and working in different teams and different projects have been helping me to open my mind and to put things into perspective. And now I just want to thank you for listening to my story and have a great day.
Okay, great. So I really like Anna's presentation because she's such an international part of the Biomechanics Society. She's really been all over. I just really wanted to bring up how the purpose of this meeting is to really get to know about our members' research, and we're all in these different stages of our career. And Anna does a really good job explaining how, you know, your passion can change throughout your career as you are curious and want to find out the answers to all these questions. We have, let's see, one more video. And this will be from Elise Passmore, who's working at the Murdoch Children's Research Institute at the Royal Children's Hospital. Let me just share my screen one more time. Does anyone have anything they want to discuss about the last presentation before I go to the last presentation of the day?
I just love that she shared like her kind of journey through it. I thought, like you said, it was really good.
Yeah, what a strong presenter too.
Yes, yeah.
Okay.
My name's Elise Passmore, and thanks for having me here, although I'm not live as it's currently 2 a.m. Here in Melbourne, Australia, where I am. So I work for the Royal Children's Hospital and also the Murdoch Children's Research Institute. So today I'm going to be talking to you about my research looking at the early identification of cerebral palsy using smartphone videos. So cerebral palsy is the most common cause of physical disability in childhood. It has a prevalence of 2 per 1,000 live births. It affects motor development and the movement and posture of the individual, and it is attributed to injury to the developing brain, either in utero or at the time of birth. Now, clinical practice guidelines recommend the detection of cerebral palsy within the first 6 months of life. And this is so that targeted intervention can occur when the brain is at its greatest neuroplasticity and the musculoskeletal system is undergoing its greatest development. However, for many, we are not achieving this, with the average age of diagnosis sitting at around 19 months of age in developed countries. So our research is focused on how we can decrease the age of cerebral palsy diagnosis. Now, we already are aware that there is certain factors that increase an infant's risk of having cerebral palsy. So these are being born premature, having a low birth weight, or being admitted to the neonatal intensive care unit. Now, for these infants, they would undergo the general movements assessment at 3 months post-term to help identify any issues with their motor development. However, for the approximately 50% of children that have cerebral palsy, they have no identifiable risk factors at the time of birth, and therefore are not detected till later when they have delayed or do not reach their developmental milestones. So the simple solution seems to be that all infants should undergo the general movements assessment at 3 months of age. However, this approach is not scalable to the population level as it relies heavily on trained assessors. So our research wanted to look at if we could predict expert general movement assessment scores from infant movement videos. We collected infant videos recorded by a parent or caregiver at home using the Baby Moves app. The Baby Moves app provides instructions to parents about what to dress the child in, and also a dotted yellow outline of where to center the infant in the video frame. And this provides 3-minute videos of the infant lying quietly on their back. We collected 505 videos this way from 327 infants. And this cohort was a mixture of both extremely premature and term controls. And videos were taken at either the 12 or 14-week post-term time point. Now, each of these videos was scored by an expert general movements assessor, and the movements were graded as being either abnormal or normal. So first we wanted to look at if we could track these movements in the smartphone videos. So we trained a deep learning model that's called DeepLab-Cut, that some of you may be familiar with, to detect the body points of interest that you can see on the image there. Now for our training data set, we used 100 of our videos, and we manually labeled 5 frames in each of these videos. And this formed our training data set. So once we had trained our DeepLab-Cut model, we could then use it to predict the body labels on unseen videos. And here's an example from one of the new videos. So the outputs from the DeepLab-Cut model give us the X and Y coordinates of each of the body points for the entire duration of the video. So we first wanted to look at how good our automatic movement tracking was. So we compared the human labels to those predicted by the DeepLab-Cut model. And we found this was quite good with a root mean square difference of 1.7 pixels. And here we have on the infant visualized the 95% confidence interval of the root mean square difference. So you can see the labeling difference is quite small. However, we also took a subset of videos and compared human annotators and found the error between human annotators to be larger at 5.8 pixels. And you can see how much larger this is by the 95% confidence interval circles around each of the body points. We also looked at there was certain factors that were affecting the performance of our model. And through a sensitivity analysis, we found that clothing that covered the hands and feet adversely affected the labeling performance of our model. Next, we looked at building our classifier to predict the general movements assessment. Now, our X and Y coordinates from the DeepLab-Cut model required some pre-processing before it could be used in our classifiers. Now, this involved outlier removal, gap filling, and adjusting for camera movement as these were handheld devices. The data was also time and size normalized. So we built a series of different models to predict the general movements assessment. Now, the one I'm going to talk about today is the one where we've achieved the best performance so far. So this is a deep learning model that used convolution neural networks. And as the input data, it took in both the movement data from the videos as well as some of the metadata. So this consisted of whether or not the infant was premature and whether it was taken at the 12 or 14-week time point. All of the models we built, we subjected to 25-fold cross-validation, where our data was split into a 70, 15, and 15 train test and held out validation data set. So we looked at evaluating the performance of our model to predict the general movements assessment. Here we have the receiver operator characteristics. Now, each of the grey lines represents one of the folds from our cross-validation, with the orange line representing the average of these. So on average, we were able to achieve an area under the curve of 0.79. Now we looked at other metrics as well. So we've reported the balanced accuracy here as our data was unbalanced with a smaller percentage having abnormal compared to normal movements. So we achieved a balanced accuracy of 70% here, and in general, through each of the folds of the cross-validation, the model results are fairly consistent. So I hope you've enjoyed hearing about some of my research where we've developed methods to automatically label and track the body points of infants in smartphone videos so we can track their movement. And here we developed a classifier to predict the general movements assessment using both the infant movement data as well as metadata that we had available. So where are we taking this research in the future? Well, currently we're working on scaling this approach to a much larger data set to test that our current approach is generalized to a new unseen data set. Alongside this, we're also working on building a classifier that can predict cerebral palsy diagnosis at age 2. So I hope you've enjoyed listening to this talk. And if you would like to reach out to me, you can reach me on the Slack channel or my email or even my Twitter handle. And I'd love to hear from people working in similar areas or have further questions they'd like to discuss. Thank you.
Okay, great. So we had a really good mix of speakers today. I think we learned a lot for doing this in future meetings. Ro, do you have anything to add?
No, I'd just like to thank all of our speakers for speaking and everybody who attended. It was a really informative session today.
And remember, you can always reach out to the speakers over Slack or over the Twitter handles that I tried to include in today's presentation. Great, I'll just stop the recording.